Okay, welcome back, you guys. We'll give everybody a few minutes to join, but as always, we're so excited to be here. And my name is Dr. Mackinville, and I'm joined by Ryan Judd, our clinical director here at the OCD Institute of Texas. Here at OCDI, we are a specialty residential and PHP, so partial hospitalization or day program that really focuses on the treatment of OCD, anxiety, and OC-related disorders. So BDD, BFRBs, et cetera. And so we love to do these webinars. The point and the reason we do them is really to provide just education and content that we know is needed to both families, individuals, and then of course also to clinicians. And so our goal for these is that you learn something new and that you're able to take this information back to your practice and be able to help patients effectively with the information shared. But also our biggest thing that we love is that this is interactive. We really want these webinars to be a time where you come with questions and we're able to answer them live. And so we typically like our webinars to be about 30 to 45 minutes and then hop into lots of active Q&A.
Yeah, and anyone who's joined before, you know that we're big CBT nerds. These webinars are all CBT based, the most evidence-based interventions for a wide variety and range of disorders. Obviously, we here at OCDI specialize in OCD and anxiety disorders, but we also treat a lot of co-occurring conditions, and CBT can be used to treat many different mental health disorders. And so I want you to keep some cases that you have currently in mind when we're presenting on today's topic and ask any questions, specific ones that you have. We love to case conceptualize and get into the nitty-gritty details, which is where all the fun happens.
So our goal for today is that we're going to talk through what CBT actually looks like in practice. And before we get to what does the intervention of CBT look like, we need to talk a lot about how you set the stage. So how are you setting the stage from a treatment or behavior plan stance? What does that look like? What should people expect? And what does CBT look like, right? And so if you understand the foundations and components of how to do CBT in treatment, everything else will kind of fall into place. It'll be pretty simple because it actually doesn't change a lot, right? The nuances change in the sense that the specifics within a treatment plan or the specifics of, how you're addressing a certain, OCD subtype or certain exposures, of course, are going to be different. But overall, the way we think about treatment from assessment to intervention to termination should be pretty standardized when you're doing CBT work. And that's what today's going to be about. We're going to help you walk through what it should look like when we think about assessment, intervention, to termination with your patients from a CBT lens, and make sure that we all feel really good about that and have a good understanding of what that looks like in practice.
Absolutely. And the main focus we're going to be targeting today is the treatment planning portion and actually introducing the treatment plan to the patient and how to use that effectively. Previous webinars went over kind of a diagnosis assessment using measure-based care, as well as some of the fundamentals of the theory of CBT and how it applies specifically to OCD and anxiety disorders. But today we're going to jump into that next step in the CBT treatment process, treatment planning, as well as going over the fundamentals of assessment and intervention.
So today we're going to talk about a few things specifically. We will talk about assessment and your formulation. So, why is assessment and intake so important? Just because a patient shows up to our office and says they have an anxiety disorder, do we just start treating the anxiety disorder? No, we need to do an assessment. We need to understand what's going on, and we need to really think about all the different factors that are play a big role in this person's life, including any potential differential diagnosis. But then we also are going to talk a lot about what are some of their maintaining factors, right? So within a CBT model, but then also maybe there's some secondary gains, maybe there's some other things that are also keeping some of these symptoms at bay. We will talk about how to build a structured treatment or behavior plan. Of course, how to think about what intervention to, really be using and how to be thoughtful about that. I think one thing Ryan, I know, disagrees strongly on is I hear a lot of clinicians saying things like, it doesn't matter if it's GAD or OCD, you treat it the same. And that's really not true, right? You use CBT, the model of the intervention in the sense of it's going to be goal oriented, it's going to be structured, there's going to be homework assignments, right? That may be the same, but the the nitty-gritty, right? The nuances are actually quite different and they're really important.
Very important, exactly. And that's why we do appropriate assessment and diagnosis because that is what's going to give you the first clues to what are the relevant treatment targets. Because if you're talking about a particular diagnosis, the treatment targets should all be somewhat similar. And then we're tailoring the interventions to fit those treatment targets, the maintaining factors. And you'll see in today's presentation how this kind of beautifully all ties into each other. The maintaining factors from a CBT lens are going to translate into treatment targets, will translate into specific interventions to work on those.
And I'm going to jump ahead, but we want to make sure we're doing measurement-based outcomes. This is a big piece of CBT as an evidence-based intervention. Every diagnosis, most diagnoses have really great validated measures available in the public domain, but if not, there's measures that you can access. But you need to be measuring, is what we're doing working? We don't want to just take that at face value of our own interpretation or, oh, it seems like the patient's getting better. We want data, we want measures to back that up for many different reasons, but it's also a validated way for us to assess and understand someone's current symptom severity. And then the second to last, which I'm going to say last because I think it's important, is CBT should always be collaborative and it should be values based. It should be flexible and hopefully fun, and I think that one bad rap that CBT gets is that people think it's this really rigid intervention. It's an intervention that, okay, you just you pull out a manual and you read from it and you follow it. That's not what CBT is, right? Maybe that's what you did when your first couple sessions, you had to study the manual, but at this point, I'm not following a manual, but I'm following a manual, right? But it's in my head at this point. But CBT doesn't mean the clinician isn't warm and empathetic and you don't build this great trusting relationship and that you're not having fun together and that you're not trusting each other during the process. That is just a basic tenet of being a good clinician. When you show up in the office with a patient, you're building rapport, you are building trust, you're slowly and systematically having them do hard things so that they can get confidence, that they can be empowered, right? That should all happen in CBT. And I want to be really clear about that because I do think that's a big misconception that CBT is this cold intervention.
Robotic and rigid, and we're just checking boxes instead of being flexible, collaborative, and dynamic, that we're making changes as we go. And that's a big part of this is CBT is empirical. So I always tell patients, and we'll get into this about the understanding component of CBT. Does the patient understand the rationale for why we're doing certain things? But I always say, I want you to do this, try this out, and come back and tell me how it goes. Because if it's not going well, we're going to make a change. We're going to tweak things, right? And that's totally flexible in our approach.
I remember a friend once who was seeing a CBT provider and they were working on anxiety treatment with her and some other life stuff had come up around her relationship and different things. And I could see where anxiety was still playing a role, but I remember her talking to me and I said, why don't you talk to your therapist about this? Have you been talking about this? And she was like, am I allowed to? And I was like, what do you mean? And she was like, well, I thought we were doing CBT and I could only talk about my anxiety. And I was like, no, CBT is a concept and a principle that you apply to your life. And if this is where your anxiety is now targeting, you need to talk about the specifics and that, so be really flexible and open and don't, work to make sure we're not creating an environment where people think that they can't come to us with other stuff that's going on and that we're not flexible. Because again, that all plays a role in your understanding and your treatment of a patient. Patients might have OCD plus 2, 3, 4 other disorders or other stuff going on. We need to know it all. It all plays a role in the way we conceptualize and understand that patient and approach treatment with them.
Absolutely.
Yeah, so we talked a little bit about this, but this is kind of what we're going to try our best to go through. We might rush through some and others not. I do want to be really clear and put a little bit of a caveat. We are going to talk a little bit about treatment planning. So if you kind of see that number 5 bullet point. However, I want to be clear, we're talking more about a behavioral treatment plan that you make in the context of CBT interventions. We're not talking today about a kind of our ethical kind of required treatment plans that we do as a part of our charts and our notes with our patient. So this isn't going to be as much of when you think of a traditional treatment plan, you think of diagnosis, what is the intervention, how long are they going to be in treatment, having a patient sign, you sign, and you have this treatment plan on file. That is important. You should follow your guidelines. You should do, the things that you do around that. This is going to be much more of a behavioral treatment plan in the context of CBT interventions.
Exactly. As an intervention in itself, as a way to summarize the psychoeducational component, we're very much going to be focusing on treatment plans that are patient facing, that are collaborative and interactive, that the patient is using with you to guide their treatment week to week. And their homework,
Yeah.
absolutely. It's going to have the homework on it. You'll see that. We're going to show you actual examples of kind of this patient-facing treatment plan that's part of the CBT intervention. But yeah, obviously certain agencies or licenses, depending on the specifics, have their own maybe formal requirements for treatment plans. And of course, you want to follow
Yeah.
that. This is more how to do a treatment plan from a CBT perspective to contain all of the relevant components of treatment and have it really be patient-facing so that your patients can be using this as their roadmap for how they're going to get better.
That's right. And one thing we'll talk about and you'll see is that this should be updated frequently. I think a lot of people, when they think of like, oh, a behavior plan, we make it at the beginning and we don't touch it. No, no, no. We're actually touching this almost every session in some way because a patient is saying, oh, like that no longer triggers me. And you can up the ante and we're adjusting it and making changes. Some things might stay the same around some of their core fears or some of their maladaptive thinking that we're, addressing and wanting them to be able to see. But as far as the work and homework, it should shift and change. And so this is a working document that you're using during treatment.
All right. So we're really talking here about treatment planning, as we said, and we are really going to be, like I said, the treatment plan should be kind of a roadmap. It's a structured document that is updated weekly. It starts at the beginning of treatment, and it should contain all of the really important components of treatment. So when we think about some of the previous webinars we did, we start with psychoeducation, and it's going to include some of the core concepts, overarching treatment goals. So what are the big picture things that we're wanting the person to do? So this is going to be something that the patient looks at. They're going to be able to reference it and not just see kind of the micro level interventions, which we'll get into in a second, but also what are the overarching treatment goals. I want to make sure one of the biggest things with CBT that I can't stress enough is that if I'm asking a patient to do something, I want to know that they understand why. Not just how to do it, that's really important. Make sure they're doing it correctly in the right way, but do they understand why I'm asking them to do this, why it's important, how it's going to help them? That's part of psychoeducation, but then it's an ongoing thing that you're kind of testing. You're questioning, asking them to repeat it back to you to teach you. Make sure that they're on board. Sometimes a patient will kind of, yeah, that makes sense. But then if you ask them, can you explain to me the rationale? You get a sense of they actually don't understand. And that's a big red flag. And you want to stop, pause, do some more psychoeducation, or alter the intervention a little bit so that you're meeting them where they're at. They can actually understand the information.
Yeah, I'll never forget. I had a family once who I was kind of doing a little bit of consulting and helping them. And I noticed that they would call me like most frequently when they were in crisis, right? Like, and not crisis like suicidality, but crisis like our daughter's having a panic attack. We don't know what to do. She's coming to us. She's asking all these questions. We're getting stuck. And after the second phone call of this, I said, do you guys have a panic protocol? And they were like, what's a panic protocol? And so I walked through what a panic protocol is, which is like, hey, let's actually like write down the steps and laminate what to do when y'all are in this level of distress in your home and like your daughter's having a panic attack and you're getting pulled in as a parent, you don't know what to do. Let's write it down step by step. And they were like, that would be amazing because we really, everything you've taught us, like it makes sense in a session, but it doesn't work at home when we're stressed and things are kind of, sorry to use the language, but like shit hits the fan, right? It's like people don't know what to do. They get overwhelmed, they get panicked. And so a part of CBT is, like Ryan said, it's about helping patients understand the why, making sure they have clear direction, but also giving them these tools that they're not going to get stuck and not be able to find their way out, right? We know patients are going to get triggered in between sessions. We know they're going to get stuck in different ways. We want them to have easy access tools, handouts, worksheets, protocols, plans. Now, again, not too many that it's overwhelming, but to where, for some of our patients, they need a sleep plan. For some of our patients, they need a panic protocol. For some of our patients, they need a script that they say when they're doing ERP because they get too stuck in their head. And so you have to learn what your patient actually needs, right? And where their symptoms show up the most, where they get stuck the most, and what that would look like. And a part of CBT's success is CBT like homework is one of the biggest components of CBT, especially if you're doing outpatient work. You can't, see somebody for 45 minutes once a week, think that if they come and do CBT for 45 minutes once a week, they're going to get better. They need to be applying those skills and applying the principles outside a session consistently. And so we want to make sure we set them up for success to be able to do it, and I think most of us would say, at least here at our program, our patients here have 24/7 support if they're living in our residential program and they still have plans, right? And they still have protocols because we need who's supporting them to make sure they're following it correctly, just like you need a parent to follow it correctly if we're talking about an adolescent. However, there often does come a time in treatment where we start to remove those plans because now they've generalized the knowledge. Now it's innate. They don't need it. The goal is not that they have to, for the rest of their life, pull out a plan and read it specifically every time they're struggling, but up front, I would much rather them do that so that I know that they're following CBT appropriately versus they're unintentionally actually reinforcing their anxiety cycle.
Exactly. Yeah. Two more things I'll add to that. Number one, why this is so important is because everyone's had the experience of a client who comes in, they're kind of all over the place. They're bringing lots of different concerns. And if we don't have a structured treatment plan that we're sharing with the patient that includes homework session to session, it's very easy to get kind of caught up and swept up in the chaos.
Yeah.
And then like we're targeting this, we're targeting that, but nothing's consistent. And then things are falling short. The patient feels like I'm not getting anywhere. I'm coming to therapy every week. I'm spending money. I'm taking my time, but I'm not making progress. You also feel frustrated because you're like, well, we were working on this, but now you're talking about this. So a treatment plan really helps you stay consistent and be able to actually focus on certain goals. Of course, we're flexible and we can add more things to it, but it also helps us stay on course. It also really, structure is such an important part of CBT. I can't tell you how many, when I talk to people, out in the public or when we do events and talks that say, I've been in therapy, but like, I don't know what to do if the person's not doing CBT or they're not doing CBT well. The patient comes in and they're like, I'm supposed to talk. They say, how am I doing? What do I want to talk about today? And I'm like, I don't know, what am I supposed to do, right? I have all these problems. I'll talk about the problems, but they're lacking structure. The patient's not supposed to know how to do therapy. That's not their job, right? Now, of course, there are some orientations of therapy that maybe that's the point, is it's led by the patient, but that's not really CBT. CBT is collaborative. Especially in the beginning, you have to really guide your patient. You providing structure. I think sometimes people who are new to CBT, like Liz said, they're worried that they're going to come off robotic or too manualized, but actually oftentimes patients need more of that in the beginning because they don't know what treatment should look like.
Yeah.
They have no idea how a therapy session should go. So a treatment plan helps provide the structure. It actually makes patients feel more like, oh, you know what you're doing. There's a plan, there's a roadmap. The other really important piece of this is that one of the biggest parts of behavior change is step one is building awareness of what are the problems, right? So you're identifying the problems in that assessment diagnosis phase that we talked about previously, and then translating that onto the treatment plan, sharing that with the patient. So when they're looking at that every day, ideally, or a couple times throughout the week in between session, they're constantly reminded of what are the things I'm supposed to be paying more attention to. Oh yeah, I have this negative belief that like I can't do hard things, or that people don't like me, or that everything I do ends up failing. Whatever that's just
Anxiety's
one example.
dangerous. Yeah.
Anxiety is dangerous. I'm avoiding anytime I feel anxious, right? We've got that written very clearly. And so the patient is engaging with it over and over and over again to keep their focus clear and constant on what actually is the problem rather than drifting all over the place and kind of saying, oh, it was this situation, it was this, this is different. It's like, no, actually, do you see the common thread here? That belief shows up in all these different situations, or this behavior shows up in all these different situations. So the treatment plan adds structure. It also it is the first step in building awareness around the problem issues.
And measure. Make sure you're doing measurements. That's a big piece we want, and we'll talk a little bit about that more actually in just a second. But yeah, so from assessment to formulation, what we're talking about is that good treatment plans are only as strong as the assessment data underneath them. So when we think about a clinical interview, your job, by the way, when a patient comes in, and I think that right now there's a big trial going on in the US and things that have made a lot of us think more about how we assess patients, questions we're asking, what we're documenting, but when you are doing that first clinical assessment and intake, you are not just trying to gather information about one thing. You are trying to understand the entire presenting problem that your patient is showing up to your office with, that they're sitting across from you with, or virtually. And what I mean by that is that, I think a lot of times, especially like when we train, we do a lot of training here, a lot of students, and when our students first show up, they'll say things like, okay, so when a patient comes, I'm really assessing for their OCD symptoms. And I'm like, not really, like maybe session 2 or 3, but session 1, we're assessing for all symptoms, right? What is your sleep? What's your eating? Right? Everything we need to know in a clinical intake to understand the potential diagnostic picture of a patient. With that being said, that can change. And I think that's really important. I think a lot of times a patient can show up and we can have a understanding conceptually based on our assessments and our primary intake of what we think is going on. And 2, 3, 4 weeks in, we're like, oh, this behavior actually might be better explained as something else than what I originally thought. And so a clinical interview, yes, the first one is probably the most important. It's where you're going to get the most information. You're doing a true diagnostic assessment and interview, and hopefully using a lot of really good questions or a lot of really good assessments, a lot of good measures, and understanding patient severity levels across all sorts of different domains. However, that should continue in different ways, right? You're continuously kind of assessing and understanding what's driving these behaviors. What are the function of the things that the patient is struggling with and showing up with? And then we're going to move to really that functional kind of analysis piece is, what is the behavior? What's the response? How do we understand it? What are the triggers, right? Really understanding what are the things that are causing this patient to get stuck in these cycles. If it's generalized anxiety disorder, if it's OCD, right? If we're talking about OCD, we need to understand the triggers. We need to understand the compulsions, external compulsions and mental compulsions. But guess what? I also need to understand all the avoidance because that plays just as big of a role in the OCD cycle as a compulsion does. And so there's a lot that goes into play based on what your patient is presenting with that then you have to understand, okay, what are all the different ways they're reinforcing this illness? What are all the different maladaptive thinking and negative patterns that are being reinforced and how? We need to have a really good understanding of that before we could ever think about doing an intervention, right? I can't do an intervention with a patient if I don't actually have a super clear understanding of the target behavior that I'm trying to address, but also of like the thoughts that that behavior contributes to.
Absolutely. And I think really important to keep in mind that all three of these have to be taken together. I can think of lots of cases, I'm sure you can too, where if you were to just isolate one of these three and go off of, an assessment, a diagnosis, a treatment plan based on only one or two of these without all three in combination, you would be totally off the mark. I'll give some examples, right? You can do a clinical interview with someone that's really thorough and they can tell you lots of things, but if you don't necessarily get collateral information, you on the onset in course and development, you might be missing something really important, right? Similarly, you could, people are underreporters or overreporters. You can learn that over time, but in the beginning, especially when a patient's new to you, you may not have a sense of that. That's where the standardized measure could come in. Sometimes patients come in, you do your initial interview with them, and they're like, "My OCD is so bad, it's really extreme." Then you do a Y box with them, and it's actually not that bad. Or the reverse, right? They come in and say, "Oh, I'm okay. It's not that bad." We see this a lot with kids and adolescents kind of downplaying. You give them a Y box and you see, actually, this is really severe. Their OCD is really extreme. But similar situation, you might give, if you have a patient with BPD, let's say, they come in and they're telling you, "I have OCD, it's all OCD," and you're going, "Okay, let me give you a Y box." Their Y box score could be off the charts. They may not even have OCD though. It's the way they're filling out that measure. You would have to then get your observations, the questions you're asking, along with patient self-report collateral and a really detailed functional analysis to be able to see, hey, even though their measure says it's this disorder based on what I'm seeing, based on other people's reports, my observations, the patient self-report, I actually don't think that makes sense. So we need all of these in tandem to actually be able to get a really accurate picture of what's going on. That's why all three of those are listed there.
And same with severity levels, so sometimes like a patient might have OCD, but if they have a comorbid, for example, BPD diagnosis, we know that patients with active BPD that hasn't been appropriately treated, their emotional sensitivity, their reactivity, right, the way they understand and feel severity levels tends to be increased. And so we might see extreme level of OCD on the Y box, but really we might like actually think that their OCD is more mild to moderate. It may not mean they don't have OCD at all, but like it's being inflated by their
momentary emotional dysregulation or a trigger they just had, or they're using it as a way to signal I'm really struggling, I need help,
exactly.
less so than as an accurate measure of their OCD. That's why these things are really, really important to keep in
Still
mind.
super important, right? It
Yeah,
tells you a
tells you
lot.
something.
It tells you something, but you need to make sure you know what it's telling you. I think a lot of times people get stuck on like Ryan said, just one thing without the other. And so you're like, oh, well, this measure tells me this. And it's like, well, maybe, but also like, what do these other things tell you and how do you put them together? But standardized measures are really important and we want that to be incorporated in, so we're understanding the diagnosis very clearly. And by the way, let me give a quick plug. Sometimes that means you're referring patients out for a full psychological assessment and evaluation. If a patient comes to your office and you're like, man, like sounds like OCD, but there could be a lot of autism. There could be other things going on. Maybe it's an emerging thought disorder. I'm really not sure. Please don't just try to fit it into an OCD box or try to fit their symptoms into an anxiety box. Have them do a really good full psychological assessment so that you have a good understanding of what's going on. So sometimes you're not doing all of this yourself. You're relying on other people. It's a team. You're collaborating with psychiatrists as well, and you're getting ROIs and you're working together. Yeah, so of course, in the CBT cycle, when we get into treatment, right? So we've done an assessment. Let's pretend that we're really treating somebody with generalized anxiety disorder. And so we're treating somebody with GAD. We know they have an anxiety disorder. That's our primary diagnosis and what they want to address, and that we're here treating. We need to think about all of the maintaining factors in the cycle of their anxiety, right? So not just a trigger and what happens, but everything in between, right? Okay, you get triggered. What is an example of a trigger? Driving my car, right? What's an automatic thought? That could be dangerous. I could get in a car accident. How does it make you feel? It makes my heart race, right? I get really anxious. I start sweating. The hair on the back of my neck stands up, and I don't know, then, okay, so then what do? Well, I don't want to feel that, so I avoid getting in a car, right? I avoid driving in a car, or I'll only drive with someone in the car with me, or I'm going to avoid freeways or things that it feels like is more dangerous. And then it creates this short-term relief, right? Okay, well, I feel better. And because I got to avoid having to drive and avoid being triggered, or because I had this safety behavior that made me feel better. We need to map this out, right? CBT should, I mean, I don't know how people do treatment without whiteboards, but like you should be using a whiteboard and like diagrams and drawing out every time they're in your office almost, right?
Yep.
Because you're helping map out the cycle and you're plugging and playing. Okay, what are your thoughts? What are the feelings? What are the behaviors that are maintaining this? What are the function of those? And why do we need to break those? What would that look like? And how do we do it? But also, are you willing to do it slowly and systematically? And what would that look like?
Exactly. And, CBT really, to kind of condense this, the cycle that you're looking at, the maintaining factors in this, like almost any problem, behavior, or cycle can fit into this pattern, right? That CBT is often looking at the patient's attempts to cope are the problem. They're
Yep.
coping in a maladaptive and an ineffectual way, and we're helping, but they don't understand that. They just think, I'm not coping well enough. I need to cope more. I need to intensify my efforts. We see that the efforts are actually part of the problem, oftentimes, 99% of the time, right? They also maybe have a misunderstanding of what the actual problem is from a CBT lens. Once you're teaching them that, hey, you think the problem is you're anxious. I actually think the problem is your beliefs about the anxiety or the behaviors you're doing to try to get rid of the anxiety, right? And any disorder you look at, that's usually what we're doing. So the whiteboard, pulling it out and helping explain that and mapping it out. Also, from kind of a humanistic standpoint, patients feel really validated
Yeah.
because number one, it shows you're trying to understand me. You're trying to help me understand myself. You care about me. And like this is helping me understand myself. I sell CBT to patients as CBT is like an instruction manual to you. We should have gotten this in like third grade.
Yeah.
We didn't, right? It's like, how does our mind work? How do our emotions work? How do thoughts work? How do beliefs work? I always, rules in CBT, we call these intermediate beliefs. Like if this, then that. If somebody doesn't blah, 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 then that must mean they don't like me. All of us have these rules,
Yeah.
right? We're operating under them all the time. We're just not aware of them. Patients will say them, especially when you do the whiteboard exercise, when you're kind of mapping out like your ABC functional analysis. We're talking about problem behaviors. We're talking about the problem cycle, what's coming up for you. That's when you'll hear them inadvertently, unknowingly, they're saying, well, I could try that, but if I do that, then this will happen. Oh, intermediate belief. Oh, core belief about yourself, about others. That's when that comes out, when you're actually doing this in session with the patient. It's giving you some really important, relevant information that will become treatment targets, that'll become future conversations, topics in sessions to address with your patient.
And by the way, I want you to start as a clinician seeing when they are generalizing this information versus when they're not. So a quick example is like I always think about I hear this all the time where patients will say, "Well, because of my anxiety, I can't work." Or because of my anxiety, I can't drive a car. And I'm like, "Oh, actually, because of your anxiety, that's more the reason why I want you working. That's actually like more the reason I want you driving a car." And they're like, "What are you talking about?" And then you map it out, right? But we want to, so even sometimes when patients will say these statements that aren't necessarily exactly what you're talking about or how the symptom you're mapping out, it's important to kind of stop and say, wait a second, What message is that sending? Like, are we generalizing the CBT concepts across the board to anxiety, or are we only talking about them for your current symptoms? That's problematic, right? CBT should be generalizable. We're going to talk about that in a minute, but everything that you learn and you teach when you are a CBT clinician, you will practice every day in your own life, right? This morning, my daughter Grace, who's 4, was like, "Mom, I did a really hard thing yesterday." I was like, "What'd you do?" She told me about some like jumping thing she was scared to do, that she jumped from here to there at this activity center that she originally like had never done, and how proud she was of herself, right? But like that's CBT in practice. I'm teaching you that, like, yeah, you were scared, you didn't want to do it, but did you do it anyways? And now my kids generalize it that they tell me every day something hard they did, right? But like we want it to be generalizable. We want you to see and to feel like it becomes a habit. It becomes second nature, that you just use CBT skills appropriately versus you respond to your anxiety or distress. All right. So how do we build the case, right? We're always going to talk about kind of predisposing factors. So we want to understand what are the genetics, what is the temperament, what's the development, right? What's one of our best predictors in psychology of future behavior? It's past behavior, right? So we, as Ryan said, we need to really understand patient's history. We need to get good collateral. We need to understand all the different things that come into play historically. And then, of course, what are their current specific triggers or events? Sometimes there is an onsetting trigger, right? There is something that maybe happened or didn't happen, right? I got bullied at school, or this thing happened, and then a lot of my different avoidance and behavior started. So we want to understand if that's the case. Sometimes it's just momentary triggers, right? There's a million of them and they can tell you them, and there's not one specific event that happened. Be cautious with this precipitating event that you don't get hyper focused on it. So in CBT, if a patient's like, yeah, no, nothing like necessarily happened, but like here's all the different things I get triggered by, don't, sometimes I think clinicians want to be like, but there must be something more. Let's talk more about that. Let's really focus on that. And I'll give an example. I talk a lot about my own diagnosis, but when I was young and my OCD first started, I was really close to my nanny. She helped raise me, and she had entered into an abusive relationship, and she would come home, like come back to our house every morning to take care of us, and sometimes she would have a busted lip and a busted eye, and it was very triggering for me. I was very worried about her. I was very anxious, and a lot of my OCD attached to that to start with. It was like, well, if I don't do, it was a lot of magical thinking, if I don't do this thing, something bad's going to happen to her. I cannot tell you the number of clinicians I went to that spent sessions trying to figure out if I was abused by this person, if something happened. And I kept saying, like, no, like there was nothing that happened. It's just what I'm triggered by right now. And it became very magical. It was very OCD. It was like, if I eat this one food, then something bad might happen. And then of course it morphed to my parents and to other people, and it started to really shift. But I think because there was this like traumatic event happening, people got so hyper focused on that must really mean something, and we need to like really unravel it. And it really didn't mean much, right? Sure, it meant enough for someone to say, like, how are you handling that? And you might want to process that quickly. But I was very clear that like this isn't the actual problem, right? The problem is my OCD and like the way it's attacking these behaviors. So, anyways, think
Exactly.
from an anxiety and CBT stance, I think sometimes when we talk about core fears, people think now we have to like unravel some childhood thing that happened, and that isn't necessarily what we're talking about.
Exactly. A lot of the research in the literature, if you look at it, will show that people are probably a lot of people, not a lot of people, significant amount of people that will seek out therapy for conditions, were maybe like kind of had this predisposition, an anxious temperament, an anxious predisposition to OCD or depression. But actually, if they're living kind of like things are going well and smoothly and they're taking care of themselves, they're kind of okay. But then a precipitating event can kind of push them over the edge and put them into that. And that's pretty common, but it's still not what you're going to be focusing on in
Yes,
treatment. You're going to be focusing on the third P, the perpetuating. What are the factors maintaining you in this cycle of depression and generalized anxiety or OCD that you're now in because of that precipitating event?
that's
Of
right.
course, you might talk about the event and you talk about, how to build resiliency, because we know that in life we're not going to avoid stressors. Actually, the more meaningful, the richer life we want to live, probably the more stressors we will encounter.
Yeah.
And so we want to build people up and build their resiliency to not be afraid of those, but knowing, hey, this could trigger you, if you're super stressed or a big life event happens, you might fall into depression. But the event isn't the problem. The problem is the way you're responding to what's going on. That's what we're really focusing on.
Yeah, and it's just so important to, again, remember CBT is about the here and now. It's about goal-oriented future treatment. And so the only real differentiator I would say is like if somebody carries a PTSD diagnosis. So if you do kind of unravel and understand in that assessment that there's a significant trauma and they meet criteria, that we're shifting things a little bit, right? So we're not talking about somebody who meets active PTSD diagnostic criteria and us ignoring that trauma and just doing CBT instead for the future because that will actually have like a negative relationship and role. But then, of course, we want to talk also about what are your strengths and supports that can help you move forward. So, do you have loved ones who can help encourage you to do hard things? Or are you going back to a mom who is also struggling with her own anxiety and going to enable yours? And it's actually going to be counterproductive from a CBT lens if we don't involve them in treatment. But we want to think about what are the supports, what are the ways in your life that treatment is going to be further enhanced versus roadblocks that are going to end up being put up. As we move to the next slide, I want to answer our first question from Melody. You asked about, when you're gathering, that you understand how important it is now to gather appropriate information and collateral during the treatment planning phase. How do you do that? So lots of different ways, so we are huge proponents of getting as many ROIs as possible. So I want a release of information for any previous current or within any recent providers. Same with family members. And then, of course, any treatment centers. If somebody has been recently hospitalized or they've had any sort of, acute diagnosis that they've been treated for mentally, and not necessarily medical diagnosis, although sometimes you may need that information as well. And you're speaking with those providers, you're getting forms filled out here at OCDI Texas for patients who come to our res and PHP. We have them fill out a family referral form and a provider referral form. And sometimes that form gives us enough collateral. Sometimes we read that form and we're like, oh, there's a couple things we really want to know more about. This would help us understand what might be going on or certain behaviors, and we need to call and get more information. But again, when you're treating a patient, the collateral is really, really important, especially with psychiatrists. If they have a psychiatrist that they're seeing, you should absolutely be talking to the psychiatrist and have a team approach because it can be really detrimental. I took a phone call after hours last night with someone who's wanting to come to our program to do some work with us on the outpatient level. And she said, if I'm seeing somebody else for grief work, is that a problem? I said, no, of course it's not a problem. However, we need an ROI, so we're talking to them because we want to make sure our interventions aren't like clashing with one another. If we're doing a CBT intervention for OCD and then they're also trying to treat some of your OCD, that is problematic. But if they're doing grief work and we're doing OCD work and it's both CBT based, but like we can separate it and we're talking about it, it will still help move you forward in both arenas. And that's the goal.
Yeah, and I would say, with outpatient care, you may not always need to get collateral if the case is really straightforward or very simple and no concerns, especially depending on what potential diagnosis you're looking at. Certain diagnoses, you definitely are going to need collateral information as part of due diligence. Other ones may be less important. But I think if you feel like you need that and it's helpful and the patient is refusing to do it, that also tells you something really important. Like, I don't want you talking to these people, or actually, no, I'm not comfortable with that. Could be, again, is important data for you to bring back to your kind of assessment and diagnosis.
Exactly. So how do we move into writing these it says treatment plan, but I'm going to call it a behavior plan instead today. First of all, we want to talk about and be able to identify what we were speaking about a second ago is what is the problem list? So prioritize kind of formulation of the patient's own problems, the things that they feel like, hey, these are my main symptoms that if I don't address them, I can't live the life I want. And also the symptoms that I'm most motivated to address because they're most problematic in my life, the most interfering. What are my short-term and long-term goals, right? What are things that I really want to be doing and I know that I'm not going to be able to do those if I don't address these symptoms. It's so important. Again, CBT is goal-oriented. We are not only talking about the problems, we're also talking about values and goals, right? What do you want? What's a life you want to be living? What are the things anxiety, OCD, a related disorder, depression, etc., has taken away from your life? How can we help get that back? That's really important because we have to help build motivation and willingness to do the hard work. And again, any short-term and even long-term goals, again, it should be very specific. So you think about these SMART goals, but specific, measurable, attainable, like all of my patients' goals, they should be challenging but feasible, right? But also very clear. If a patient comes to me and says, yeah, I probably wash my hands 1,000 times a day and I'm taking a 3-hour shower. And so my goal is to wash my hands less. What does that mean? Like, how do we measure that? How do we know if you were successful? Like, what does less mean week 1 versus week 2 versus week 12, right? We want to be really specific.
Yeah, the devil's in the details, right? Like, okay, I'll wash my hands, two fewer times, but then they're using more soap,
Right.
or they're,
Yep.
not using the hand towel or something. And it's like it's just another compensatory behavior. You have to be very specific about, well, okay, well, how's that actually going to look? What are the limitations of
How
all
is it
these
actually going
things?
to be an exposure that's going to target
Mhm.
decreasing the cycle versus still enabling it? Because that can happen even if someone decreases a ritual, that it can still be enabled in a different way. Oh, I avoid touching these things now so that I don't have to wash. And then again, what are the specific interventions we're using, right? If somebody is living with OCD and GAD, we're going to be talking about ERP for OCD, which is the specific CBT intervention you do for OCD, and we're going to be talking about CBT for GAD that looks a little bit different, and so we want to really make sure the patients understand why it's different and what it looks like. I feel like I'm constantly bringing out a whiteboard in our office here because a lot of our patients have a lot of comorbidities that aren't all treated with just even CBT. And so sometimes I'm drawing this like diagram of, okay, where's your OCD? Where's your anxiety? And where are like the interpersonal difficulties you're having? And how do we differentiate these? Because we're actually not going to use ERP for interpersonal stuff. We're going to use more DBT skills for interpersonal, but we're not going to use DBT for OCD. So we want to really be clear. We want to make sure the patients have that knowledge. You shouldn't own the knowledge as the therapist. A lot of times I think therapists forget that the goal is that the patient becomes their own therapist, right? We want them to be way more versed in the intervention and the symptoms and, the maintaining factors of their own illness than we are, because they're the ones that have to do that work in the evenings and after hours and, on their own. And so make sure that you're thinking about not just sharing what the intervention is, but making sure they understand what it is and why and when to use it for, what symptoms to use it for. And then, of course, we're constantly addressing this behavior plan. Every week, we're revising it, we're updating it, we're giving new measures. Sometimes you might give a measure beginning, middle, and end, like the Y box to understand severity. Some people might do it every 2 weeks, but you're tracking progress, you're understanding what's working, what isn't working. If a patient comes in every week and says they didn't do their homework, please don't keep assigning the same homework if they keep having that same problem. Slow down and figure out why. Is it too hard? Are they not making time for it? Are they not committed to treatment? Like, we need to stop and adjust so that they can have success. That's really important in CBT.
And to answer the question, we will be sharing the slides.
Yes.
And this webinar also will be posted, the recording, so you can rewatch it if you'd like. Um, yeah, so it's kind of sequencing of interventions. This is really important. And I think this is newer clinicians will sometimes get a little overwhelmed with this. But this is where that like flexibility and collaborative approach comes in. Where do you start with? There's a lot of different philosophies and theories about this. I feel like with CBT, you can't really go wrong. You have a couple of options. You could either go with what is the patient most motivated to work on, right? That really puts them in the driver's seat, and they're probably going to be more likely to follow through on the work. You might identify what do I think is the largest source of distress, and let me go after that first, because if we can get that under control, that might bring them, more capability to work on other things, right? So we could go for like the thing that's distressing them the most, the thing they're most willing to work on. Of course, if safety is ever at risk, we're going to have to, by default, target that first. But you also want another school of thought.
Priority, to just be like thoughtful of like, okay, if I'm trying to do ERP with a patient or CBT, which is going to be dysregulating and it's going to be distressing, but this patient has a substance use history that hasn't been addressed, like they need to address that first. Otherwise, the dysregulation is going to could lead to dangerous behaviors, so you should be really thoughtful of like, okay, this might be most distressing, but this actually isn't warranted to do this work first because there's not a safety risk there.
Totally. Another school of thought is like you want early on to get your patient to have a couple of really good wins. And so you might start with smaller, more feasible things to begin with, because then they're more likely to follow through and be successful. That builds their sense of confidence. They're proud of themselves. They're ready to take on more. That's another, way that you could sequence this. Usually with CBT, we say that the behavioral interventions are the best starting points, because when we change behaviors, we expect that mood will also change. We also expect that cognitions, beliefs, those kind of rules will also start to soften, and they'll be easier to address cognitively if we've already started to kind of challenge them behaviorally. But that's not always the case. That's usually the case, but sometimes a belief is so strong it's blocking any type of behavioral change, and we have to address the belief first. So there's no real right or wrong. This is why CBT is empirical. It's flexible. It's a theory that can kind of be molded to the individual and their circumstances. And so you want to be looking for that. You'll know the sequencing is correct because the patient's reporting progress. You're able to move on and address more and more things each session.
Exactly. And again, keep the plan, keep the work, keep the intervention collaborative and flexible. Again, we're updating, we're fixing it, we're changing it. A patient's coming in saying, "Hey, I really don't see the benefit in this work. I don't want to do it." You're like, "Okay, then what do we do instead? And why is that important?" Do make sure that's not an avoidance, right? And like we want to kind of be thoughtful of like, is that really in your best interest? And talk to them about it, But I'm a big believer. So for me, what I like to do, and we're going to show a behavior plan here in a second, is I help make a behavior plan. It's always made with the patient, right? They're seeing everything you write, they're talking to you about it, they're on board with it, they agree, they want to do these exposures. About halfway through treatment, I'm actually emailing the behavior plan to the patient and asking them to update it every week themselves. Why am I doing this? Well, because I'm teaching them to be their own clinician. My goal is to work myself out of a job and to work them into a fulfilling life that's free from their anxiety, which means they have to be able to teach themselves, coach themselves, have the tools in their own brain automatically. And so we want them to take ownership, right? Like let them edit the plan, let them edit what they're going to work on. I will review it and make edits and say, wait a second, this sounds like a ritual, or like, we're a little confused here, and like, let's walk through it, but it's how they really learn.
Yeah, you start off being very, very instructive, directive coach. You're kind of really directing everything, and you kind of work your way into being more of a consultant. Like, hey, I'll weigh in on this, I'll give you, but really this is about you taking radical ownership. That's great for you as a therapist. Number one, you're going to feel so good when you see your patient really driving this process, telling you what they need, what they want to do, where they want to go with this. But also it really sends the message of like, a person's the problem they come in with in your office, it's never their fault, but it is their responsibility to change it if they want to, right?
That's
That's not on
CBT,
you.
right?
Exactly.
Like if you don't believe that, then you're going to struggle doing CBT work. Just
Exactly. Yeah. And you will get stuck because the patient will come in and kind of put this on you. Well, you're my therapist. This is your response. I'm not getting better. What
yeah.
are you going to do about it? That is fundamentally antithetical to the principles of CBT. But as Liz was saying, kind of slowly putting more and more of the responsibility and ownership, especially as the patient's understanding increases and their sense of self and their ability to do things increases is really great. It's wonderful for you as a therapist, and it's what's best for the patient.
Yeah. And think about it with anyone, right? But like you have a baby, right? At first you're feeding your baby, right, but eventually you're teaching them to feed themselves. You're wanting them to, and they become more and more independent with time. You don't want to be feeding a teenager the way you're feeding a toddler, right? That's going to be pretty
Not going to
like
work.
not going to work well for them and for many reasons. So it's the same thing. We're slowly teaching skills, but we're building confidence, right? We're doing it in a collaborative way that is empowering, makes them feel good. I'm not expecting a toddler on day one to know how to get their own food and cook and use a stovetop, right? But like it's a process. Yeah, so of course we're always going to kind of think through cases from, again, these main tenets, if that's what we want to say, but like what is the presentation that they're showing up? What are the maintaining factors? Do we know them? Have we identified them? Do we understand the full picture and presentation of what's going on? And also, does that presentation match an orientation, a theoretical orientation that should be applied? So what I mean by that is, okay, have I really teased apart what's going on to say, okay, this is all OCD, or this is OCD and panic disorder, or this is OCD, panic, and BPD? Like, what is going on? Based on what I know is going on, I'm then going to identify which interventions need to be happening. Sometimes it's one intervention can address multiple. Sometimes it's different interventions for each thing. So we need to really think about that. And then, of course, we start to build those goals and work through what this intervention will look like in practice. And we slowly and surely start doing interventions with the least anxiety provoking things, working our way up, right? You think of it in this hierarchical manner that we want to build success. Again, I wouldn't throw, a 2-year-old on a bike without training wheels and without a helmet and say, good luck in Houston. But we're going to slowly teach you, right? How to learn to ride a bike, what that looks like, how to stay safe. And before we ask you or expect you to ride your bike to school on your own.
All right, so we've actually
A little
got
small,
some.
sorry.
You can see that. Hopefully, you can kind of zoom in. But we actually put in some examples. Of course, these have been edited for HIPAA compliance to protect privacy. But these are actual examples of interventions that we use. We've got the overarching treatment target. So again, the patient is really clear, no matter what micro intervention we're doing, what particular activity, whether that's a specific type of behavioral activation, it's a behavioral experiment, it's an exposure, it's filling out a thought record. Those are kind of your micro level interventions or therapeutic activities, but it should always be related back to what is the overarching goal here? Why, and that goes back to that rationale for this. Why are we doing this? How is this going to help you? What are you trying to learn? What are you trying to change by doing this thing? That's those overarching treatment goals. They're usually big, they're broad, they're addressing patterns of behavior, overall beliefs, overarching beliefs.
And this is the kind of like, then what kind of Socratic questioning. So, a patient will come in and say, I can't drive my car. And you're like, okay, well, let's walk through why. I'm too anxious. Okay, well, like, what would it mean to like drive your car if anxious? Well, that could be dangerous. So what happens if it's dangerous? Something bad could happen. Oh, I could get in a car accident, right? But like, we want to really understand these core fears and beliefs on this like much more granular level. So if you can still say, and then what, and they have another answer, you actually haven't gotten there, right? Like you want to stop when it's like, well, that's it. Like, then I would have to live with that guilt and I don't know how I could do it. So what are you actually afraid of? I'm afraid that if something bad happens, I'd have to live with the guilt and I don't know that I can tolerate that, right? That becomes a core fear, a core belief that we're going to note and target because we want them to remember that that's actually what's driving a lot of these behaviors that we're going to be addressing.
Mhm.
And so then we list, as you'll see on the previous slide, sorry, you'll see that we will list like what are the behaviors, what are the avoidances that you currently do? So what are the things you're doing that are maintaining the illness, that are maintaining the cycle, and the maladaptive thinking, all of the above. And then what are your overarching treatment goals? Like what do you want to do? I want to be able to drive my car to work freely. And I want to be able to like actually listen to music and enjoy my car ride and not be triggered, right? But what are the different goals you have?
And listing the problem behaviors or the safety behaviors, the problem avoidance behaviors, again, kind of increases the patient's awareness because remember, when they come in, they're thinking those things are actually their attempt to cope. Oh,
Yeah.
this is how I'm going to feel better if I just do more of this or if I do this better.
And they think they have to do it.
They think they have to
Yeah.
do it, right? And that's true with any disorder. I'm depressed, so I can't get out of bed. I'm lying in bed because that's the only way I can feel better. They really believe that that's their attempt at coping with feeling terrible about themselves or having really negative beliefs about themselves. We're able to see that that's actually making the situation worse. So by listing those specific problem behaviors as part of the treatment plan, things to look out for, things to avoid, things to reduce systematically over time, it increases the patient's awareness. They're looking at this every day, ideally saying like, oh yeah, if I catch myself going to wash my hands, if I catch myself going to, you know what, I'm going to Uber to work today instead of drive, they're like more aware of that, more likely to then do something different.
That's right.
The next slide is a little bit more specific in terms of the treatment plan listing. Like we said, kind of the interventions, the short-term goals, the in between session homework. So these are very specific activities. Again, it could be behavioral intervention. So exposures, what are things you're going to go do that you're afraid to do or worried about doing? Or a specific behavioral challenge. So we call them behavioral experiments, but you want to translate all of this into language that's patient friendly. So we can, with kids, we might call it like a, superhero challenge, or this is your like face your fears challenge, whatever makes sense.
Yeah.
Gamify it so that the patient can connect with it, they understand it, and they're more likely to follow through with it. So here's some examples of just specific activities that we want the patient to be working on in between session.
And we tried to differentiate it. So you'll see this one is actually focused. Slide one was more on an OCD case. This is more on a body dysmorphic disorder case. And so this is not as much direct ERP, but this is more CBT for BDD and what that would look like. But what you're going to see is that it's very specific around goals, right? We want you to reduce reassurance seeking. We want you no longer talking about your appearance and seeking reassurance or asking questions about it. Why? Because that keeps you stuck, right? That continues to tell yourself there's a problem. And we want you to challenge those beliefs. Again, how? By things that we'd all be willing to do. You'll see in there, right? Things like, I want you to go to a coffee shop, have a conversation with someone. I'm not saying go to a coffee shop, purposely imagine that you look bad. We're not asking you to do that. We'll talk later and we'll do different presentations of what BDD treatment should look like versus not. We don't go to these worst case scenarios. It's, hey, can we teach you and build confidence and trust in yourself that you can do these things in your disordered thinking, right? Which is what the disorder is. It causes this disordered thinking. Doesn't have to continue to play a role in your life. And we actually can change that to no longer be disordered and to be normative and for you to actually have good views and thoughts about yourself and your appearance, but it's not going to happen by telling yourself and talking out of it. It's going to happen through behavior. And that's the whole premise of CBT. And so what you'll see is that the slide two, right? So a behavior plan, by the way, it's usually just like one document. It might be 2 or 3 pages. It might be on one page. The first slide that we showed, that doesn't change as much. You may not be changing that every week, maybe not even much at all. This section, which is actually the active exposures that you're doing and the things that you're reducing, this is what should be changing often because we should be continuing to up the ante. My like thing I listen a lot for is for patients to tell me they're bored. If they're like, Liz, I think I'm doing something wrong. I've been doing this exposure and like it's boring. I'm like, awesome. That means it's not triggering anymore. It's not activating you. Time to move on to the next level. We're going to swap it out for something that's more challenging. Some of the pitfalls of behavior planning are that we're not specific. And sometimes we are letting patients select interventions that are more focused on feeling good and comfort than actually addressing the target. So in CBT, I'll give a good example. I say this all the time. All right, somebody's really triggered. People will actually write in behavior plans and I'll say, why is this there? But they'll write, if your anxiety gets to a certain level, go do this instead to feel better. Or oh, okay, if you get triggered, go do mindfulness. We have to be really careful, right? We in CBT, we're actually approaching fear, we're approaching anxiety, we're sending the message we're not afraid of it, it's not dangerous. We don't want patients to do things that send a separate or different message, right? That message of like, oh, but if it gets too bad, you can't tolerate it. Or, oh, in that case, you actually need to do something to feel better. No, we don't want to send that message. Again, never skip the patient's voice. You should not be the one making exposures, making a behavior plan. Your patient should be doing it with you. It should be collaborative. They should actually be the ones that kind of are like convincing you of what they want to do before you're trying to convince them. And again, we need to know, we need to be doing measures so that we know if what we're doing is working, right? Are they getting better? And here's just a key indicator. If a patient is doing CBT homework and they're coming to you and they're saying, I'm still just as triggered, it is your job to say, okay, well, then what are we doing wrong? Right? There's either some sort of safety behavior maintaining factor, you didn't understand how to do the exposure correctly. There's something going on because CBT should actually work quickly. If someone's doing homework, which means they're doing it consistently and frequently throughout the week, they should see significant progress in as little as 1 week around a certain symptom that they were targeting. If they're not, you need to sit back and figure out why. Yeah, so these are some of our biggest key takeaways. Formation is really like the key. You can't start an intervention if you don't have a clear understanding of a diagnosis, what's going on, what the maintaining factors are, secondary gains, all sorts of things that play a role in the understanding of someone's behaviors. Number 2, structure is critical. You can't do CBT without structure. So if you're not planning, if you're not prepping, if you're just showing up and it's a free-flowing conversation, your patients are going to feel like they're not getting anywhere. You might think, oh, that was therapeutic. They got to chat about it. That's not what CBT is. CBT is not meant to be therapeutic talk therapy. It is meant to be goal-oriented, directed, and very structured. Collaboration drives outcomes. We always know this, right? If I'm telling a patient what to do or I'm not listening to them, we're not going to get anywhere. And the measurement is a really important key indicator for us to know what we're doing is working and for the patients to see it too. A lot of different EMRs will have access to public domain measures. If not, you might do it on your own and have it in different ways. Of course, get approval if it's not available in the public domain. But like for us, we're able to map and we will show our patients and show the family members what their measurement scores are. And they can see it every week in our program to see what their depression level, what their OCD level started at, where it's at now. If we see it stalling and plateauing, that's important. We want to know why, what's going on. We're putting that in our notes and documenting because it's good for us to constantly be aware of like, oh, they were making great progress and they've kind of stalled. What
What's going
happened?
on? Exactly. Well, this has been a great topic. We have a couple questions that we can answer. Um, the first one, how would you approach a fear of being kidnapped? Teen has difficulty sleeping through the night, wakes up frequently 3 to 4 times a week, and runs to parents' or siblings' room.
Yeah. So, I mean, the first thing I want to do is, of course, make sure there hasn't been a history or something that's happened that they do feel like their safety is at risk and that instead this is an irrational thought. But if it's an irrational thought, I want you to map it out in the CBT triangle. I want you to look at what are the maintaining factors. So what are the things they do? Okay, well, every time they're triggered, they go sleep with a sibling or with their parent. So what does that tell them? It tells them that there actually could be danger, right? That they need to be in someone else's room. But what other things do they do? I bet you will also uncover other safety behaviors that they're doing maybe before bedtime or during bedtime, whether it's like watching the clock, listening to noises, doing certain things. So it may make more sense to start with some of those lower level, safety behaviors that you can identify first before we start to remove going into siblings' rooms. But we want to, slowly and systematically do that. Okay, like, how many times can you limit sleeping in your siblings' room this week? Okay, well, I'm only going to sleep in their room twice this week. Okay, great. Well, let's start there. And actually, let's limit that to you can go and stay in their room for 1 hour, or you can go in their room after 2 in the morning versus if you usually go at midnight, right? And how do we slowly kind of tailor it back? But again, the goal is exactly what you think. Eventually, it's to be able to have a fear, but not respond to that fear and instead respond to your values, which is being able to be independent and stay in your own room. And so you can have a fear or a thought, just like all of us do, right? We can be in our room and hear a noise or hear something happening and decide, are we going to respond to that? Or are we going to kind of say, I don't know what that is and let it be there? If we respond to it, it becomes bigger, it becomes magnified, we're reinforcing it. If we respond to our values, we decrease it.
Yeah, and you kind of alluded in the beginning to the cognitive element. You want to really try to assess for like what is the thing that's really driving this. So they might wake up with a fear of I feel like I'm gonna be kidnapped. How much do they believe that? What age are they, right? Because depending on how old they are, we might
Right.
actually add in a lot of like reassurance or information. But if they're an older teen and they know I probably won't be kidnapped, but I'm just like panicked and I don't want to sit with the panic, then it's actually more about panic and sitting with fear and scary thoughts than it is. They know I'm probably not going to be kidnapped, but I'm just like, I can't calm down unless I go find my mom. It's more of a comfort thing. So depending on what their beliefs and their thoughts about the situation really could kind of, again, direct which way you're going to go with treatment. Um,
And be thoughtful to do it like we don't do these sort of like bigger kidnapping fears for the first time at night.
yeah,
It's like,
yeah,
oh, can we
exactly.
actually like talk about this in office during the day when you're not as triggered by it? Can we think about the other
Exactly.
things that you're afraid of when you feel anxious? And can we target those first before we work our way up?
And you can also give them kind of like a replacement behavior. So instead of running to the parents' room, they can say kind of like a confidence statement, like I'm really scared that I'm going to be kidnapped, but it's just fear, it's just a thought. I can handle this. I'm strong. I'm safe. And I'm going to try to go back to bed, or I'm going to turn on a light, read a book, and go back to bed. So some kind of replacement alternative, more adaptive behavior than the one they've been using.
That's right. And again, slow and systematic should be hard, but should be feasible. And we will work to send out and give recommendations for some of our favorite measures and what we do. If you haven't, please go to our website at ocditexas.com. Subscribe to our newsletter because in our newsletter, we like to do a monthly newsletter. This last month's was specific to panic disorder. And in those, we are doing a lot of attachments of like PDFs and cycles and information that you can always
Yeah.
download and have access
The
to.
newsletter is really, I have to say, it's really
It's
incredible.
well done. Yeah,
Really, really
we're
good
really proud of
clinical
it. So.
resources.
And all of that's also available on the website for download, our past newsletters and whatnot. How do you balance CBT with very person-centered approaches? Like, listen, CBT is person-centered, right? It is still an approach in which it's collaborative. I don't know. I don't know how to explain.
Yeah, active listening. We are, unconditional positive regard. All those core tenets of kind of the humanistic, Rogerian therapy were integrated into CBT. We should be person-centered. We should be, listening to our patients, actively soliciting their feedback. I mean, that's one of the tenets of CBT. Every couple of sessions, you should be actively soliciting feedback. How's this working for you? How are our sessions? Could I do anything differently that would be more helpful for you? Really, and like Lisa, kind of mapping out a person's problems is very person-centered. You're literally demonstrating to the person how much you care about them because you really want to understand them and what's going on. So the two are absolutely compatible. There's really no conflict in those two.
Yeah, two last things I want to say, and we'll get to this last question at the end is remember that CBT is an evidence-based intervention. So if you're doing CBT, you should be doing it for interventions that you know it's evidence-based for. Person-centered approach is not like an evidence-based intervention for OCD or an anxiety disorder, right? You still need a specific intervention that you're doing. And so it doesn't mean, I think, again, this is where there's that belief sometimes that like CBT means I have to like throw out my listening skills or like I'm not going to be as collaborative. That is maybe like how you approach and how your kind of personality is as a clinician. But CBT is the structure of the sessions, and so if you are at conflict with CBT, if you're like, I don't know if I could do CBT, I don't know if I would be good at doing exposures with patients because that would be hard and triggering for me. I do want you to sit down and think about that because we actually don't want you doing CBT if you feel in conflict with it and because it will send the wrong message. When a patient is struggling and anxious, if you can't tolerate that and encourage them to face their anxiety, you will unintentionally reinforce it and it can be unhelpful. So sit and think about that a little bit. I think that's really important. The last question, two last questions. Do we do more in-depth trainings? We are always offering lots of trainings and lots of options. So check out our website for that. We'll be happy to share more. You can also always reach out to us directly. You can find our information on the website, and we will be happy to share different ways that you can get connected and learn more about OCD and anxiety treatment. And the final question, Ryan, is how do you adjust ERP for social anxiety if there's neurodivergence in the mix? So how do we make sure we're not invalidating real processing differences that might actually exist while addressing the social anxiety?
Yeah, great question. We do this all the time. I would say two major things to think about. Number one is really kind of going back to that person-centered neuroaffirming. So we're going to look at the different ways that the person understands the world and interacts and what are their values around social interactions, what kind of outcomes do they want to have, what kind of experiences they want to have. And then we're going to tailor the ERP to actually fit with what they're telling you they want and what they would like. So that's really important. And then also kind of validating how difficult it can be for autistic individuals, neurodivergent individuals to go into those spaces that are kind of set up not necessarily tailored to their specific needs, right? We can really validate that and also tweak ERP to fit that. And the second thing is, are we assessing for social skills deficits or social or missing certain information about social interactions that the patient, we just kind of assume people know or understand when really they may not, right? And you can also do that, even social skills and social information, social learning, you can do that in a neuroaffirming way, which is like making sure the person has the information or understands the skill and saying, do you want to use this skill? I've had patients who said, yeah, thanks for teaching me how, neurotypical people would go about this interaction. I don't really want to do it that way. Okay, that's
Okay,
great.
yeah, and we want to know
Yeah.
that. I don't want to tell you to do something that you don't
Exactly.
do. And we were actually talking about this yesterday, but we see this a lot with like autism and OCD as well, right? Where with OCD, we're actually trying to get you to get rid of all the rules and be totally flexible. Where for some patients with, say, autism and contamination OCD, they might actually still need some rules, right? Maybe they need guidelines and rules around what is normative, what isn't, around how much body wash you use or your shower routine or different things. And that is how they're going to function appropriately, and ERP is tailored for that. So again, that assessment is so critical because we need to understand, is this OCD, is this social anxiety, are there other things going on, and what is it? What does it look like? And how do we treat that whole person? CBT is meant to be collaborative. It is meant to still treat the whole person 100% of the time. So we love being here. Thank y'all for joining us. Again, go to ocditexas.com to find all of our webinars, resources, information. Reach out with any questions that you have. Thanks for joining, and we'll see you guys next month.